Welcome, everyone. Today we're delving into one of the most commonly ordered, yet often misunderstood panels in clinical medicine, liver enzyme tests. These labs are pivotal in identifying liver disease, but they also offer insights into systemic conditions, and interpreting them correctly is critical for getting the diagnosis right. So whether you're a student, a clinician, or just a curious learner, this is your comprehensive guide to making sense of liver enzymes. Liver enzyme tests are used to assess hepatocellular integrity, biliary function, and general hepatic performance. But here's the thing. Just because the liver enzymes are elevated, that doesn't mean the liver is the only organ involved. Enzymes like AST and ALP are found in other tissues, so context is everything. These labs play a role in evaluating everything from autoimmune hepatitis to fatty liver, drug toxicity, infections, and even infiltrative diseases like amyloidosis or lymphoma. Let's break down the major players, what they do, where they're found, and what their elevations really mean. ALT is your go-to enzyme for hepatocellular injury. It lives almost exclusively in liver cells. If ALT is elevated, especially if it's more than 10 times the upper limit of normal, think acute viral hepatitis, ischemic hepatitis, or drug-induced liver injury. On the other hand, mild elevations can occur with chronic conditions like NAFLD or from medications such as statins. AST is found in a wider range of tissues, not just the liver. You'll also find it in the heart, muscles, kidneys, and red blood cells. Here's a clinical pearl. An AST-ALT ratio too strongly suggests alcohol-related liver disease. A ratio 1, that's more consistent with chronic viral hepatitis or NAFLD. Also remember, AST can rise in conditions unrelated to the liver, like muscle trauma or myocardial infarction. ALP is found in liver bile ducts, bones, intestines, and the placenta. If ALP is elevated, ask yourself, is it hepatic, bone-related, or something else? High ALP in the setting of liver disease points to cholestasis, bile flow obstruction, or disease of the biliary system. This includes gallstones, primary biliary cholangitis, primary sclerosing cholangitis. To confirm the source, bring in GGT. GGT is highly sensitive but not specific. It rises with alcohol use, drugs like phenytoin, cholestatic injury. But if both ALP and GGT are elevated, then you can be pretty confident that the ALP elevation is hepatic in origin, not bone. LDH is everywhere in the liver, heart, muscle, and red cells. You won't use LDH to evaluate routine liver disease, but it can help in massive hepatocyte necrosis like in ischemic hepatitis or severe hemolysis. Liver enzyme interpretation is all about patterns. Here's a simple framework. Pattern enzymes, elevated common causes. Hepatocellular ALT, AST, especially viral hepatitis, autoimmune hepatitis, drugs, ischemia. Cholestatic ALP, GG, biliary obstruction, cholangitis, infiltrative disease. Mixed ALT, AST plus ALP, both elevated drug-induced injury, viral hepatitis, autoimmune hepatitis. Isolated bilirubin, normal enzymes, elevated Bailey-Gilbert syndrome, hemolysis. To get more specific, calculate the R factor.
R-, LT, ULN alt, ALP, ULN ALP.
R means 5. Cholestatic. R between 2 and 5, mixed. When you see abnormal liver enzymes, follow this process.
1. Look at the pattern. Is it hepatocellular, cholestatic, or mixed?
2. Take a thorough history. Doubt. Prescription meds, supplements, and OTCs. Viral exposures or travel. Family history. Symptoms like jaundice, fatigue, pruritus, or right upper quadrant pain. 3. Order additional labs. Autoimmune panel, ANA. Metabolic workup, iron studies, ceruloplasmin, alpha-1 antitrypsin. Get imaging. Start with right upper quadrant ultrasound. If needed, escalate T or ERCP. If muscle injury is suspected, check CPK and possibly aldolase. Let's list the common causes by category. Benign or transient. Vigorous exercise. Statins or NSAID. Gilbert syndrome. Infectious. Telnatus E. Current. Sepsis. Autoimmune. Autoimmune hepatitis. primary biliary cholangitis, primary sclerosing cholangitis, metabolic, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, drug or toxin-induced acetaminophen, amiodarone, herbal supplements, methotrexate, other, ischemic hepatitis, malignancy, hepatic infiltration, cardiac congestion, celiac disease, sometimes mildly elevated transaminases. How do we follow up? Mild, isolated elevations, repeat in 2 to 4 weeks, often improves with lifestyle changes or stopping an offending drug. Persistent or worsening abnormalities, time to order serologies and imaging. Acute or severe elevations or signs of synthetic dysfunction like elevated INR or low albumin warrant a referral to hepatology. Liver enzyme tests are powerful tools, but they must be interpreted in clinical context. A pattern-based approach combined with a solid history and focused testing will help you pinpoint the cause and avoid unnecessary investigations. Thanks for joining me today. If you found this helpful, feel free to share, review, or reach out with questions. Until next time, keep learning and keep questioning.